So this talk is about can foot exercises and going barefoot improve function, muscle size, foot pressure during walking, and qualitative reports of function in people with flat foot. My co-author is Dr. Kiefer Hutchinson, and I'd like to recognize the graduate students from George Fox who helped out with this project. Started measuring foot inversion and plantar flexion strength as a sign of posterior tib weakness in patients with acquired flat foot deformity in 2008 and demonstrated a 30% weakness using this kind of instrumented system. And you can see here's an example of how we extracted those measurements. Using this device, Dr. Neville was able to identify that most controls are symmetrical from side to side for the most part, but that posterior tib subjects that are classified as stage 2 or have a flexible flat foot deformity or really have this bimodal pattern where there's a strong group and a weak group. And he was able to demonstrate the strong group actually kind of move their feet better than people with weak muscles. In other words, using 3D motion analysis, he's able to demonstrate that plantar flexion of the forefoot was better in the patients that were strong versus weak, meaning that they had better arch raising than the weak group. Heather Barskin, a follow-up study in 2013 using some of these same methodologies, looked at patients after lateral column lengthening surgery. So these are patients that had a reconstructive surgery for their arch, flat foot. Essentially, bringing them back in for evaluation at long-term follow-up demonstrated that while the LCL surgery raised the medial longitudinal arch, it didn't improve the forefoot plantar flexion motion that was typical of most flat foot patients. In other words, the same patients here in Dr. Neville's study who weren't able to improve their flat foot function that were weak. In other words, they didn't have arch raising during walking. This also was not restored using the lateral column lengthening surgery. So in a subsequent study using for conservative care, we evaluated whether strength and bracing was better than bracing alone. And what we discovered essentially was that there were minimal improvements to adding strength to bracing, but overall, when you took these patients just as a group, that means both the strong and the weak group here, strengthening was not superior to bracing alone in terms of symptoms and self-reported outcome. So what this made us wonder is if we had pushed the envelope enough on the exercise program and how we actually strengthen the foot. So we decided to step back and study asymptomatic flat foot. And so this is some data on asymptomatic flat foot. Essentially, Anjan et al. Did a diagnostic ultrasound to look at circumferential and thickness measurements of several leg and foot muscles. And they're kind of plotted here. The cross-sectional area graph is plotted here, comparing normal foot to pes planus. And we can see is that there's specific hypertrophy of some foot muscles while there's atrophy of others, suggesting that strength is important in terms of the adaptation to the increased motion that flat foot presents to the foot. And so in other words, what we've seen is that the foot's a little bit more unstable when you have an acquired flat foot deformity. And in a follow-up analysis, what they were able to show is that the arch height and statically is correlated quite highly to plantar flexion thickness and the cross-sectional area of these muscles. Now the challenge of current foot and ankle research is how exactly do you train these muscles? And so you can see here's an example of a doming exercise that's been promoted as a way of raising the arch. And you can see very specifically you get quite a nice medial longitudinal arch raising with this exercise. Notice how the toes are not plantar flexing, but essentially it's very difficult to give resistance during this exercise. And so then there's also very specific strengthening exercises you can give with the therotubing, and this particular one is the plantar flexion and adduction of the forefoot. That's associated with strengthening the posterior tibialis muscle. And then the standing exercise here is where you're holding the doming while the person internally rotates their foot. And what we know is that the internal rotation of the tibia would lower the arch, and that kind of challenges the foot muscles to maintain that arch. So this kind of resisted trunk internal rotation is a nice progressive resistance exercise to how to train the person to maintain an arch or domed position. Now, as good as exercises are and how we've kind of specifically laid it out here, their transference to walking is an open question. So barefoot weight bearing may be another strategy that gets this transference to occur. So consider that even somebody who is walking at 1 meter per second for 30 minutes takes 2,000 steps. And so as we're trying to rehabilitate people, just walking without shoes could be a very strong stimulus to kind of rehabilitate the foot and ankle muscles. And most therapists should openly question the ability of exercises that are only done at a few reps to actually match the biomechanical needs of the foot when it comes to not just walking slow, but walking a normal amount, which is up to 10,000 steps a day. So in essence, an exercise program, that is comprehensive might include movement, strength exercises, and then activities that have the adequate repetitions and functional meaning to transfer this to everyday life. So essentially, building on these principles, we had a sample of asymptomatic flat-foot patients, and they're kind of reviewed here. And in particular, we can see how they were different. They're mostly kind of younger to middle age, and essentially they differed on the foot posture index quite dramatically, which was intentional. So essentially about half the flat-foot participants in this were classified as extreme flat-foot. So the FPI scale was from 0 to 12, where above 10 is extreme flat-foot, and then from 6 to 10 is moderate flat-foot. And so the average was 9, with half falling into the moderate and half falling into the extreme range. The control participants that are shown here were in the neutral foot range. And then the only difference at baseline in all the variables we're going to review was the number of repetitions of heel rises, which was kind of surprising to us, but essentially there were about 7 heel rise repetitions lower on the left and right side when compared to the control participants. So the intervention was essentially the exercises that we reviewed, except for toe spreading. We also added toe spreading into the rehab protocol. And then we did the protocol over an 8-week time period with a booster session at the 4-week point. And the outcomes included very specific muscle tests, which was a diagnostic ultrasound circumferential measures of the abductor hallucis muscle. We also did a force plate-based paper grip test, where you have a piece of paper under the big toe, and you pull the paper out and record the amount of force the person has pushing down into the paper to try to keep you from removing it. We also standardized our heel rise assessment, where we measured heel height, and we also measured repetitions, and we used a metronome for this, and measured heel height on every repetition, and then stopped the measurement when heel height dropped below 75% of maximum heel rise. We also recorded foot pressure data at a controlled speed and used 5 trials of normal walking for our average, and then used kind of accepted masks to measure peak pressure, average pressure, and force. The last thing we did was got a qualitative assessment and compliance data with the exercise program. This was only done in 13 patients, however, in terms of the qualitative part. But we asked them an open-ended question: did you feel there was a benefit from participating in the study, and was the exercise routine reasonable? And then our compliance equations are down here. So here are the results. So this is the busy graph of the pre-exercise versus post-exercise data, and you can see that averaged here. And then here's the different variables. The mean differences are listed here. All of them were significant, and you can see the p-values over here. There's so many were significant. It may be a better evaluation of the data to look more at the effect size to get a sense if it's clinically meaningful. And so here the we just use the interpretation of the effect size index, which is kind of fairly well accepted, that a 0.5 or larger suggests a medium effect, and a 0.8 or larger a large effect. And so if we look at this, we can see that the right heel rise repetition was a little bit lower than a medium effect. All the others are above a medium effect, and then we can see that heel rise height was essentially a very strong effect, and that also the physiologic cross-sectional area also fit that definition. So essentially, heel height and muscle cross-sectional area all have very large effects for this 8-week interval exercise program. And so here we kind of show that those two variables a little closer. So essentially, the heel rise height increased by about 2 centimeters, and that really indicates improved plantar flexion of the forefoot. We know that about 50% of heel rise height can be attributed to the midfoot function, not just the ankle. And so essentially, this increase in height is hypothesized for this to come from the forefoot, not the ankle. And essentially that led to increased ankle function, though, where on repetitions, although these patients didn't do any ankle calf work at all, so if you think back about the exercise program, there's no ankle-specific exercises that would reasonably increase ankle plantar flexion. We still saw a 7 rep average increase in the left and right side that really brought them back up to the same value as the controls. So the appealing hypothesis here is that the increased stability of the forefoot improved their ankle plantar flexion function. There were no differences in the foot pressure data in any of the masks, though, at the 2 spots evaluated, the 30 and 70% pressure points. And qualitative data suggests that of the 13 patients assessed, 9 used terms that were considered positive responses, like strength, balance, hurt less, less fatigue, and awareness, so they're conscious of their feet. Another theme that emerged from the qualitative analysis was that some patients thought the barefoot walking or barefoot kind of activities took too much time. Others thought it took too little. And then some thought it was too easy. Some thought that the exercises were too hard. So you can look at this maybe as hitting the right balance, or that your programs really need to be tailored to those people. And so the compliance was exceptionally high for both the exercises and the barefoot weight bearing period. So the key findings is that these exercises were past the proof of concept test, meaning that they demonstrated physiologic changes in terms of muscle size and force output in the paper grip test. What was more surprising to us was the increase in heel height and repetition. While we expected some change in heel height, the repetitions were surprising. And this would be the first study to demonstrate changes in the foot that are connected to ankle function. However, the transference to walking was not confirmed by alterations in foot pressure data. And I guess the qualitative data also suggests that there's some benefit to the exercises that the patients were able to perceive, even though at a functional level it's hard to argue that there was a strong outcome in terms of sports performance or something like that. And then finally, it can't be underemphasized the importance of a control group, especially for something like the qualitative data and then the increase in ankle repetitions. Overall, the key findings, though, appear to be that this approach would be effective in terms of increasing muscle size and force.